Respected convener, moderator, and delegates, good afternoon. At the outset, I would like to express my gratitude to the organizing committee for giving me the opportunity to be the part of this academic feast. So, what is third eye? So, in our ophthalmic practice, we occasionally come across the term third eye. However, there is some confusion regarding its existence and nature. Some believe it is real, while others argue that this does not exist. Opinions differ on whether it has a physical basis or a purely spiritual concept. Here, I would like to present few aspects related to the third eye. So, as an ophthalmologist, we know regarding the two external eyes, which receives light energy and convert it to electromagnetic energy and send signals to the occipital lobe and make us to see the world around us. But there is one more organ that receives light energy through ganglion cells of the retina and make us to get insight. That organ is pineal gland, also known as third eye. In some lower vertebrates, the parietal eye is a primitive light sensitive organ located on the top of the head. It helps to regulate circadian rhythm and dictates chances or changes in the ambient light. The human pineal gland is thought to be a vestigial remnant of this revolutionary or evolutionary adaptation. Pineal gland is a small, a cone-shaped endocrine gland situated behind the third ventricle between the cerebral hemispheres. It is about 0.8 centimeters long and roughly around 100 millimeters. It is supplied by the choroidal branch of the posterior cerebral artery. It is having a nerve supply that is sympathetic from superior cervical ganglion and parasympathetic from the pterygopalatine ganglion and otic ganglion. Its main function is secretion of the melatonin. This pineal gland, being a part of the diencephalon, is centrally located and connected with various areas, either by neuroanatomical pathway or by neurochemical pathway, and influences their functions. How it is connected to the neuroanatomical pathway? Ganglion cells of the retina, approximately around 2000 to 10,000 cells, send their axons to the suprachiasmatic nucleus. From there, so in a polysynaptic pathway, they go to the paraventricular nucleus of the hypothalamus. From there, it goes to the intermediolateral cell column of the spinal cord. From the spinal cord, preganglionic fibers goes to the superior cervical ganglion. From there, postganglionic fibers goes to the pineal gland. This pineal gland, so all other systems including brain are connected with pineal gland by a neurochemical pathway, that is through melatonin hormone secreted by the pineal gland. Melatonin exerts its action through M1 and M2 receptors. What are the functions of the pineal gland? The main function of the pineal gland is the circadian rhythm. It is also called as body's internal clock that regulates various physical, mental, behavioral changes, primarily influencing by the light and dark. So, what are the other functions of the pineal gland? It also takes some role immunity function. It acts as a antioxidant and protects the nervous system, regulates the reproductive system and menstrual cycle by rhythmic hormonal function. Mood regulation and mental health protected by the sleep and wake cycle. It also having other functions like helping in providing insight, executive function, planning, decision making, higher consciousness, spatial awareness, and sensory processing and proprioception, memory and emotions. So this is regarding the anatomical way. So there is another aspect of the third eye, that is spiritual eye. It is also called a mind's eye or inner eye or eye of wisdom. It is invisible eye, usually depicted as located in the middle of the forehead, slightly above the junction of the eyebrows. It is referred to sixth of seven chakras, and it is called as Ajna chakra. So Lord Shiva depicted with three eyes, referred to as Triyambaka Deva. So the ordinary two eyes sees the external world, which is divided dichotomously, that is good and bad, sunset, sun rising, dark and light, left ideology or right ideology. This spiritual eye is a little higher level to the ordinary eyes and higher vision, having a special ability to see the external world above the relative dichotomy. When persons goes above this divided world, the individual is going to become divine, that is divinity. I is self and it is different from the mind. So the content of I is awareness, consciousness and bhava. The I, that is self awareness, is centered in insula of the brain. The ordinary human being functions with ordinary I, that is limited self, and so the extraordinary human beings will work with high evolved I, works with higher insightfulness. So thereby he expands limited self to unlimited universal self, where he sees the world as Vasudaika Kutumbam. So latest neurosciences with the advanced neuroimaging techniques like PET scan or functional MRI, dynamic daily mental function or mind function is explained by network hypothesis. So a normal ordinary person is in default mode network. Firing is present in ventromedial prefrontal cortex and posterior cingulate cortex. So which is depicted in red color in the first picture. Persons doing day-to-day activity, memorizing, performing daily works will have firing in so dorsolateral prefrontal cortex and in posterior parietal cortex, depicted with blue color. Persons doing sadhana and meditation, firing in the anterior insula and in the anterior cingulate cortex is depicted in yellow color. A person with higher insight, persons of excellence, will able to switch from a reddish default mode network to bluish executive network to fulfill the day-to-day excellence in work. So activation of the third eye can be achieved by various sadhanas and meditations. Ajna chakra activates pineal glands via insular activation. The I, that is self awareness, from the center of the insular cortex by practice of yoga and meditation coordinates with pineal gland and executive function of both frontal lobes where hypothetical spiritual eye is present. Yoga and spirituality helps a person to grow from I to V. So studies on meditation sadhanas have proven that increased cortical thickness in prefrontal cortex and insula showed improved white matter integrity in the anterior cingulate gyrus after few weeks of meditation. Here I would like to mention few sadhanas and their influence. Sadhana of Gayatri Mantra will help to know self from non-self. So corrects orientation of time, place and person. This correct orientation will guide the individual to differentiate self from non-self. This will help us unifying inner world and outer world by balancing our thoughts, emotions, and behavior. Sandhya Vandana, a sacred time to pray the Almighty. So, monitoring noon and evening. Dashadina, Dasha Disha Namaskar. So, that is praying 10 sides of the space. Trikala Sandhya increases orientation of time, place, and person. So, Dasha Disha Namaskar in mind, it increases the space in the mind. Yoga and meditation stimulates insular cortex, pineal gland, and frontal lobes and help in getting the higher insight. So, in conclusion, the third eye is a fascinating concept that bridges biological science and spirituality. While the third eye is often linked to spirituality, its neurological basis involves the pineal gland in the posterior part of the brain, that is Sahasra Chakra. Spiritual eye, Agna Chakra in the anterior part of the brain, and both will be coordinated by the insular cortex, which is the center of eye, that is self awareness. This eye evolves into a higher level of insightfulness by increasing self awareness. The insular cortex expands its space to the infinite level with the help of left parietal, that is a right left orientation, and right parietal, a spatial orientation. With yoga, meditation, and spirituality, the ordinary person with limited eye level with concrete thinking evolves into a higher level of eye, that is eye to V. So, pineal gland regulates light sensitive sleep wake cycle of the body and other biological rhythms. However, advanced yoga, meditation, and spirituality can create and experience the expanded vision with enhanced perception, which may align with traditional third eye concept. Thank you.
Thank you, Dr. Bharat Kumar. For those who may not be familiar, Dr. Bharat Kumar is the president of Telangana Ophthalmological Society. Very insightful talk, and I think makes us all think beyond ophthalmology.
Yeah, this concept is really
dimension.
working for, especially from my glaucoma point of view. Like Dr. Tanush Dada at AIMS, he did a study of the mindful meditation, and breathing 365 is really helping patients. Especially though I have started recommending to my patients through one of our yoga instructors, like I am getting a 15 to 20% drop in intraocular pressure. In selected cases, this thing can certainly be prescribed, and we are getting due results, and it is scientific, proof scientific now. So with that we can move on to the
I
next.
request the next speaker, Dr. Malika Goel, senior ophthalmologist at the Apollo Hospital in Hyderabad. She will speak to us on management of diabetic macular edema.
Good afternoon, everyone. I'll be speaking mostly on the practical aspects of management rather than what's already available in the literature. Yes. So how many here do actually manage a diabetic macular edema, so that I know what I am speaking to? I think the girls at the back, are you PG students? Yes?
Varangal.
Yeah, so there's hardly anybody here who's going to manage diabetic macular edema.
Let them learn.
They might become retina specialists, you never know.
Yeah. Yeah, you are already. I don't need to-
Malika,
yeah.
AIOS conferences, you don't have to look there. You look at your talk is being recorded and it is available on YouTube.
Oh, okay, great. That's a
Okay,
good point.
so you go-
Thanks. Okay, great. So we'll speak about management of diabetic macular edema. The basic principle remains good systemic control of blood sugar, blood pressure, serum lipids, anemia, renal status. This is the foundation. And this can show results within 6 weeks. And following this only, is the serial anti-VEGF injections, which are the first line ocular therapy. Laser, intravitreal steroids and vitrectomy have only secondary roles in particular cases. So when we see a patient of diabetic macular edema, only the one which is in the white square, that is the area which we treat, which is center involving diabetic macular edema with visual reduction. If the vision is better than 20/32 and there is very mild edema, this can be left alone and left under observation. Can you stop this photographs? Thanks. On the other hand, if the edema is not involving the center, then this can be treated with focal laser if required, and that should be enough. Now, it was only in 2008 that we first started seeing excellent visual recovery with treatment, which was with anti-VEGF agents such as ranibizumab. Before this, only laser was available, which was not showing improvement in vision, but only stabilization of vision. Following ranibizumab showing improvement, we had aflibercept coming in, which showed that not only vision improves compared to laser, where 11 letters with aflibercept and not even 1 letter improvement with laser, but also aflibercept was able to, I'm sorry, this animation is not working, but also aflibercept was able to increase the treatment interval to 2 months from 1 month with the same results. So then we had newer and newer agents with longer duration of action, so that fewer injections were required. In India, we now have faricimab, which allows injection every 4 months in up to 60% of the patients. And now we are expecting Eylea high dose, which is 8 mg aflibercept, which will allow 4 monthly injections in 90% of the patients. So this is a big relief and reduced treatment burden. So to intravitreal injection, these are the options which we have already discussed. In addition, there is steroids, triamcinolone acetonide or dexamethasone implant. The protocol of treatment, now we do not treat patients who have reasonably good vision and very mild edema. Some fluid can be ignored if vision is good, because there is no benefit to treatment as has been found in the recent studies. So just observe these patients. Earlier we used to treat these patients, but now we do not treat them. The current protocol is, if vision is less than 20/32, we treat with monthly injections for 6 injections, and then at the end of 6th month, if there is persistent macular edema, we take the patient for laser. However, we can stop the injections before 6 if the vision is improved and the edema is negligible, or if in the last 2 injections there is no further change in vision or edema status. Continue injections if there is, even beyond 6 injections, if there is any improvement in the last 2 injections. And stop if it is stable, but restart as soon as you see worsening of edema or visual acuity. The mere presence of some fluid at macula is not an indication for treatment. When we say worsening or improvement, we mean a minimum 5-letter change or a 1 Snellen line visual change, or a minimum of 10% central subfoveal thickness change on OCT. Now, why do we give 6 injections instead of 3? Is when we stop at 3, we have 52% of eyes that have persistent edema, but going to 6 injections, it reduces to only 32% of the eyes that have persistent edema, with further 3-letter improvement in vision. Which anti-VEGF to be used? The landmark trial was the protocol T, which showed us that in the overall group of patients, there is no difference whether you use ranibizumab or aflibercept, but in those that have significantly poor vision, there aflibercept gave a better response at 1 year, but by the end of 2 years, ranibizumab and aflibercept gave similar response. However, Avastin or bevacizumab continued to perform poorly, with persistent DME more likely with this drug. So in summary, in eyes with more severe macular edema or poorer vision, aflibercept or one of these stronger drugs may have a better response than ranibizumab, at least at 1 year. The other concept which has come up is that prompt treatment is much better than delaying the treatment. If you delay the treatment by 2 years, then giving injections even monthly, you get only a 4.5-letter gain compared to 11-letter gain if you had started right at presentation. So prompt treatment is also important. Now, how long do we need to give these injections? Unlike AMD, these injections can be reduced significantly after the first year. Up to 20 to 30% of the patients do not need injections even in the second year, and almost no patient may need after the third year, without losing the benefit, the visual benefits that they got in the first year. The only problem with stopping injections is that there is a, the very high risk of progression to proliferative diabetic retinopathy when anti-VEGF dosing is reduced. Contralateral eye often benefits, so check the patient before injecting. We may not need injection in the other eye. There is no benefit found to giving injection. I'm sorry about the animation. Okay. There's no benefit found to treating the non-perfusion peripheral areas as regards number of injections or reduced or improved visual acuity. Macular exudates, very important. Once they come, they are very resistant to treatment and they lead to permanent vision loss. So the treatment involves systemic control, injections and laser. This is a patient who was very non-compliant with very high lipid profile, and over 1.5 years significant deterioration, but within 6 months, once he agreed to periodic injections and systemic control, you can see the improvement with vision also. The another lady where continued to deteriorate with widely spaced injections, but once we controlled her systemic disease and the injections, you can see that now the lipids have resolved, edema has resolved, and there's no further injections required in the last 1 year. And no laser was required, no steroid was injected. Similarly, other patients, here you can see that the lipids have resolved, but the vision has actually deteriorated because of the lipids at the macula. So that is why it is very important to prevent foveal involvement rather than chase it once it has come. Intravitreal steroids can be used even after vitrectomy. They have intravitreal steroids have a long duration of action, but even the newer anti-VEGF agents have a comparable duration of action where the IOP rise is seen following steroid injection. Laser is recommended for eyes with persistent cystoid diabetic macular edema, and it improves the long-term outcome, which may be required in up to 40 to 60% of the patients following injections because they continue to have persistent macular edema. To do a laser, we need an angiography, which should be separated from an injection by at least 3 days because they may interact, the fluorescein and the intravitreal injection. And once the macular thickening has reduced, about 4 weeks later, laser is done. The role of steroids in DME is for persistent macular edema which doesn't respond to anti-VEGF agents, or when there is a planned cataract surgery where it covers the inflammatory component, and where anti-VEGFs are contraindicated due to pregnancy, recent cerebrovascular events, and severe renal disease. Problem with steroids being cataract and intraocular pressure elevation, so contraindicated in glaucoma and immunocompromised patients. Also, dexamethasone should not be injected in patients with large PC opening or a scleral fixated IOL. This is my own patient where it migrated into the anterior chamber, causing corneal decompensation. Imaging, how much time do I have? Yeah, okay.
Need to conclude.
Okay. Fluorescein angiography continues to have a role because it tells us the diagnosis. Here we might think it is diabetic maculopathy, but this FFA shows that it is BRVO, and it shows us the area of leakage where we need to treat. As in this patient, fluorescein is showing us the area of leakage, the arrow, where we need to do the laser, which cannot be shown by the OCT angiography. Fluorescein also picks up new vessels in hazy media, which OCT angio cannot. And surgical intervention, Dr. Babu will be speaking, but generally related only if there is a traction. Many times we find that just with injection or with scatter laser, the macular traction has been released and surgery is not required. So there should not be any undue hurry towards surgery. However, some cases, as you see before and after surgery, they respond to injections only after surgery. And some patients never respond, but we need to treat just to prevent worsening. DME worsens following cataract and glaucoma surgery, so should be treated before the surgery, or at least at the end of surgery an injection should be given. And the last point about NSA drops for DME has been found to be of no use in the management of DME, but we do use it for DME prophylaxis following scatter laser and cataract surgery. Thank you.
Thank you, Malika. Now, after the management of diabetic macular edema, let us go to the anterior segment and topic of interest, which lens to choose, comparison of visual outcomes with IHANS and VVT.
Afternoon,
Dr.
friends.
Madhukar Reddy.
Yeah. Post lunch, all of you are here. Thank you for coming for this session.
This is a sort of an alumni of AP and Telangana.
So coming to the evolution of intraocular lenses, all of us have gone through monofocal lenses, then multifocal lenses, and now extended depth of focus lenses are the flavor of the season. And they have some advantages and disadvantages. From the patient's perspective, an ideal lens is which gives near, intermediate and distance without any dysphotopsia or decrease in contrast sensitivity. That's the natural lens below 40 years of age. That's what a patient wants. But the present day technology is still evolving and we don't have an ideal lens. So recently, a few years back, we had these IHANS lenses from J&J, which were better than the monofocal lenses. They were giving some intermediate vision because they have tweaked the asphericity and then gave some extension of the intermediate vision. Then VVT lens had come 2-3 years back by Alcon, which had a bump and which were giving a little bit more of the intermediate and near vision. So we were using both and we just wanted to know what is the benefit, because the cost of the lenses were 4 times more of VVT lenses compared to J&J lenses. So just to give a simplified overview of our results, we compared the uncorrected distance and near visual acuity post-operatively at 4 weeks of 100 recipients of each of these lenses. So it's not hi-fi research like contrast sensitivity and all those things, but just basically from the clinical perspective, we compared IHANS lenses and VVT and VVT toric lenses, 100 each from each consecutive series, and we found that unaided distance vision was 6/6 in 43% of IHANS and 58% of VVT lenses, and with the other commensurate of visual acuity. The target refraction for IHANS was somewhere between 0 to 0.5, because we wanted a little more on the negative side rather than the positive side, whereas for VVT it was aimed at distance for 0 power, because that way the company recommends that there will be adequate distance and near vision. Near vision, which the patient usually feels that that's a success of the surgery. So IHANS lenses gave us N6 vision in 18% of patients, whereas VVT and VVT toric gave 46%. So there's definitely 50% of the patients with VVT lenses were having were very comfortable with distance, intermediate and near. So that's the advantage compared to IHANS lenses. And there was no significant glare or halos in either of these lenses, because a significant number of patients who drive at night, we've implanted VVT lenses and they were very happy with those lenses and nobody really complained. But the downside is IHANS lenses are nearly 4 times less expensive than VVT lenses. So we need to advise these lenses for relatively well-off patients. And both groups were counseled that they have to wear glasses for near, because not to make them over-expectant. So to conclude, VVT and VVT toric lenses had greater spectacle independence. About 46% had N6 vision compared to IHANS lenses, which was about 18%. Thank you very much for your attention.
Thank you, Dr. Madhukar. Very interesting, and it is intriguing to see that a good number of your IHANS patients had N6.
Yes.
Yeah, so that's, even though it's not traditionally an extended depth of focus lens, it's more of an enhanced monofocal. But some of these patients do get pretty good near vision, and at 40 centimeters they can actually see N6. I think one needs to qualify at what distance you're seeing N6.
N6.
Yes,
Normal reading distance, they were able
so
to see
whether
it.
it's 33 or 40,
Yeah.
sometimes, you know, at 33 they may not see, but they may see it at 40.
Yeah.
So, but it's interesting times actually, and increasingly we are finding ourselves moving more towards these lenses rather than bifocals and trifocals because of the better optics, and they also in evolution. The EDOFs also are in so many different optic mechanisms are there for different EDOF lenses. So I think we'll have to see which one stands the test of time and which ones we eventually end up using. Recently, new one has been launched from J&J, and then their Lentis M Plus has a one lens called Femtis, which is specifically made for a femtocataract, in which the lens clips onto the capsular axis, and it's got varifocal optics. So a lot of new lenses coming in, and very interesting times.
And also these are more forgiving if there's any other EDOF lenses compared to multifocal lenses are more forgiving if there's any minor corneal opacity or macular problems.
I also noticed in your series you said you didn't have any patients with any visual complaints, but I did have a couple of my VVT patients who were unhappy with the quality of vision, and I couldn't think of any other reason but the
I'll
actual
get there soon.
yeah. So any questions from the audience? Come into the mic.
Yeah.
Recording or
So
we have
recently
time.
iHands is giving more of N8. That's my experience. Even
Yeah.
after repeating I'm not sure whether they have
Some will
changed
get
the
N6,
bump.
some will get N10, some will get N18 also. It's
Yeah,
very
but
variable. That's the whole problem. It's unpredictable.
But the multifocal lenses I find are having much lesser glare and halos. So unless there's a straightforward contraindication like diabetics or some glaucoma,
But multifocal lenses nowadays everybody drives at night. Most of the people.
but they're not giving.
They
I'm
get
not sure what your
adapted to it.
experience is. Yeah.
Yeah, but in case whatever is the traditional thing, if something goes wrong, a lot of nowadays medical tourism is also there. US patients come and they have to drive at night, otherwise they're disabled. So one patient is enough to.
Yeah, I'll tell you one thing, Charita, my experience. One of my patients, she doesn't drive at night. I specifically asked her. Her sister had a trifocal lens because she was just not suitable for anything else, and she had a clear lens, but she just didn't want to wear glasses. So we went ahead and did a clear lens exchange with trifocal. Very happy. Seeing her sister came to me, who was a fashion designer. Now I put a trifocal lens, Plano 66N6. But extremely unhappy. Why? Because in her studio where she does the designing, she has LED lights. LED lights are everywhere, and those can also give halos. So you don't know which patient will be unhappy. That's the problem with these lenses.
I've seen one patient with multifocal put 10 years ago, diabetic and retinopathy has developed now.
Yeah, that's what I want to enhance, that multifocal sprays differ in patients with retinal conditions. In future, it becomes very tough for us to manage the retinal conditions.
How about EDOF lenses, VVT lenses? Is it good for doing laser?
Yeah.
Better than
multifocal.
multifocals.
Yeah. Okay. With this, we will go to the next.
I'm Dr. Rahul Shukla. I am from Jabalpur, Madhya Pradesh. Next is the MPSOS session, so I've come here a bit early. So there was a study which was done by Dr. Mayank Nanavati, the EACRS study, wherein a monofocal IOL is also giving N6 vision in around 8 to 9% of the patients. So if your IQ or your technique gives you an N6, don't feel surprised and don't feel that you have done something extraordinary. There are 9% of the patients who would give you an N6 vision. Right? Yeah, definitely iHands is something which is a more forgiving lens. And if you explain it to the patient, I think it becomes much easier for you. It puts less burden on the budget. The pocket is really safe. Yes, EDOF is a better way. I mean, VVT is obviously much better. There's no doubt about it. Just wanted to highlight this fact.
Thank you for that. And now we quickly move on to the next speaker, Dr. Rishi Swarup. Actually, he designed the whole the session, and he will be speaking on AIOS2025 finding in recurrent corneal erosion syndrome. OCT with a different purpose.
Hello. Yeah. Thank you, Dr. Ajit Babu. So this talk will also be a little short, so we'll catch up on time. So this is a study that we have done in our hospital to highlight the role of OCT in recurrent corneal erosion syndrome, which is something very common actually, but often underdiagnosed in the clinic. So this is typically what a classic recurrent corneal erosion syndrome cornea looks like. You'll see this whitish kind of a loose epithelium, and if you stain with fluorescein, it will have negative staining around it. And recurrent corneal erosion syndrome is a relapsing chronic disease of the corneal epithelium characterized by repeated episodes of sudden onset of ocular pain, discomfort, watering, irritation, etc. Typically, these symptoms come up when the patient wakes up from deep sleep, and on sudden opening of the eyes, the symptoms start, and they last for a short period of time, from few hours to few days, and they spontaneously go away either with treatment or without. And so they are called the so-called morning symptoms. And pathology basically is that the attachments, hemidesmosomal attachments between the epithelial cells and the epithelial basement membrane gets damaged, and even when the new epithelium forms, these attachments don't form properly, and that's why this epithelium tends to keep getting ripped off again and again, causing recurrent symptoms. So the most common etiology for epithelial basement membrane is actually trauma. Commonly, fingernail injury is the most common. Typically, we see it in mothers whose children have put their fingers in the eyes. But paper edge, the paper cuts, and any other object, plastic toy falling into the eye, these are the common trauma indications that we've heard. Other than that, epithelial basement membrane dystrophy is a dystrophy of the epithelium, which is prone to develop recurrent corneal erosions, and various other corneal dystrophies also are prone, as is listed here in this table, and other conditions, etc. also you may see. So any condition, even a refractive surgery like PRK, when you're removing the epithelium with a blade, if the edge where ablation is not done, can start developing erosions as well. So recurrent corneal erosion syndrome, in between the episodes, the cornea looks absolutely normal. So if the patient told you that 3 days back I had these symptoms and he's come to your clinic, the cornea will be absolutely normal. You do OCT, you do clinical examination, you may not see anything. So history becomes very important, and it's important to proactively ask for these, when does these symptoms happen, if they and ask if this have happened before, any history of trauma in the past which triggered the first episode. And of course, when they come during the episode, then looking at them in the slit lamp and also use of tools like the anterior segment OCT becomes important. So the purpose of this study was to report the findings of OCT in corneas, the recurrent corneal erosion syndrome, and the secondary objective was to see the role of PTK in treating this condition. So this was a cross-sectional observational study of 46 eyes of 34 patients performed at our hospital. All the eyes were scanned using the OptoView RTView 17-line raster acquisition protocol of the OCT, and the etiology was investigated and the standard treatment protocol was started. Scans were obtained at various stages of the pathology and studied for different changes in the different layers of the cornea. So this is the typical layers in the epithelium in the OCT. You can see the epithelium, epithelium, Bowman's epithelial basement membrane, and the Bowman's membrane in the magnified view of the lens. So we had patients with recurrent corneal erosion syndromes in 17 ladies and 11 men. 8 of these patients had underlying epithelial basement membrane dystrophies, which was 17%, and all the AIOS-OCT images were obtained were compared with normal AIOS-OCT images, and changes were noted. So these were the changes that were seen in the epithelium. We see changes in the epithelial basement membrane, Bowman's membrane junction, and then changes in the anterior stroma. So epithelial changes, the most common was epithelial edema, which is thickening of the epithelium, irregular breaks in the epithelium, seen in 40%, undetected epithelial basement membrane in 53%, intraepithelial basement membrane. I'll show you images of all of these, how they look, and intraepithelial inclusions. The BM changes, which is the Bowman's membrane, basement membrane changes, were thickening of the junction in 71%. Hyperreflectivity was the most common sign across the board, 88%, and slit-like spaces in between the two layers. And stromal changes like anterior stromal hyperreflectivity, which is basically because of scarring in the anterior stroma. So I'll just show you what these changes look like in the OCT. On the top, you can see the thickening of the epithelium, which is the epithelial edema. Intraepithelial basement membrane is that hyperreflective line there, and intraepithelial hyperreflective inclusion is that thickened mass in the epithelium over there. Irregular breaks in the epithelium with overlying intact tear film, and that is the absence of the epithelial basement membrane in this image here. The BMBM changes were slit-like spaces. So these have not been described before our study. There have been other studies, but this is something we found very commonly in our population, and hyperreflectivity and thickening of the BMBM junction, as is shown in the second image. And finally, in the anterior stroma, you can see anterior stromal hyperreflectivity, which can be either from edema or from scarring. So 11 of these eyes underwent excimer PTK between 1 to 15 microns, following which 10 of these 11 eyes had complete resolution of symptoms as well as OCT changes noted previously. One had partial resolution. So similar study of 25 eyes is the only other study by D.S. Fejo et al. And the major difference our study could pick up was various changes at the level of the BMBM junction, which were not mentioned in the previous study. In fact, they were the most common findings that we found. And this layer should be studied in greater detail, as the tight junctions are present here, and this is the actual site of the pathology rather than just the epithelium. Epithelium is just secondary changes. So you can see the percentages in comparison to their study and ours, and these were the parameters which additionally we found in our study. So to conclude, corneal OCT is a useful tool to study the pathophysiology and of recurrent corneal erosion syndrome and its evolution through various stages of the disease. It also helps in planning its management, especially when deciding the depth and size of ablation during PTK procedure. So you can actually see how deep the pathology is and accordingly plan your excimer ablation. We don't need to really go deeper than 10-15 microns, because that's where the pathology really is. Thank you.
Thank you, Rishi. Now we move on to the next talk, vitreoretinal interface disorders by Dr. Ajit Babu Marji. Yeah, yes, Madhukar, you can stay.
Hello? Hello? PTK. Yeah, so the machine that we are using, which you are also using, is the Schwind, which it removes more epithelium in the periphery than in the center. So the refractive effect of that is almost near zero. So if you go for a small optic zone, it may cause a hyperopic shift. But again, our ablation depth is so small, 10-15 microns, that itself will not really cause much of a refractive effect. So it's pretty much safe. Yeah.
Thank you, Manoj Mathur, and at the outset I would like to thank Telangana Ophthalmic Society and All India Ophthalmological Society for providing this opportunity for us to share the knowledge with you. And today I will be sharing my experience in vitreoretinal interface disorders. What is the vitreoretinal interface? It is the most posterior part of the posterior hyaloid layer and internal limiting membrane. The interface is always very thin, see, 100 to 300 microns, and the lot of disorders can happen in this, and I listed all the disorders here, but I will discuss some of them, because it is from PVD to epiretinal membrane to macular hole, pseudo hole, and full thickness macular hole. So the first of it is, though many people think that posterior vitreous detachment is very innocuous, actually it is most dangerous. If you see the age, even at 50, 25 also, there can be posterior vitreous detachment, which can result in retinal detachment. Though below 50 it is 10%, and at 70 it is almost 50% of the people can have PVD. This can result in rhegmatogenous retinal detachment, and a close follow-up up to 2 months is very essential. This patient is a 60-year-old female, came with vitreous hemorrhage, and I called her. Luckily, after a week, you observe there is a temporal retinal detachment with tregma. So what I did is, I given some gas and did a cryo. After 2 weeks, that has healed. There is another break, and the detachment is extended. So here the vitreous detachment is completely not relieved. So we had to do vitrectomy and completely cover all the breaks to give a good result. Luckily, she never lost the 6/6 central vision all through follow-up. And if you go for vitreomacular adhesion or traction, which Mallika was referring, we should see what type of traction we are dealing with and what is the stretch it is having. And these tractions should be relieved. And most of these tractions should be relieved by surgical interventions. Like this patient is having macular traction, and we have done pars plana vitrectomy, ILM peeling, and fluid gas exchange. ILM peeling is very, very essential here, but how we do it is also essential. Means you should go around the macular center so that there is will not be any creation of macular hole in these patients, and a good result has come. See, 25-40 vision in these patients is very good. And another disease pattern of vitreoretinal interface disorders is epiretinal membrane, which can cause decrease in the vision. And the type of epiretinal membranes decide how successful you will be and how to plan during your surgery. So the plane on OCT is very, very essential here. Here this membrane is not very tightly adherent to the retina, and it can be easily removed. There are certain membranes which can happen, not in this case, but the next case. Here also it came out nicely, and the foveal contour is retained, and vision also comes very nicely. This case, there is adhesion, and there is the tentacles are going into the retina. Here the dissection can be very tricky, and you should be very, very careful while dissecting the epiretinal membrane in these cases, because certain times retinal tears can happen, and it may lead to retinal detachment while you are removing the retinal detachment. So I'm lucky that it came out very nicely, and then the result will also be good. The last one is the macular hole, but clinically you need to identify lamellar macular hole from a full thickness macular hole. The lamellar macular holes again can be inner lamellar macular hole and outer lamellar macular hole. Both lamellar macular holes do not require any intervention. This is important. Clinically you identify lamellar macular hole, easily you can follow without losing further vision of that patient, and close follow-up is required. However, once full thickness macular hole develops, in 95% of the times we can close the hole and we can improve the visual acuity. So that is the importance in identifying what type of hole we are really encountering in the clinic. So this patient we intervened, and you can see the outcome. Visual outcome is 20/20, which you can't anticipate with otherwise. Only follow-up do not give this. And again another patient of macular hole and 20/80 vision, good outcome. The contour is good, the outer layers are good, and neurosensory, retinal neurosensory, that is rods and cones layers, is also getting improved. In albinotic funduses, you see the contrast is very poor. So here mainly the chromovitrectomy and staining is important. Of course, we nowadays do staining in all the cases, but here it is much more important so that the ILM peeling can be very, very facilitated and the outcomes can be good. So even in this albinotic fundus, we could achieve a very good surgical outcome. With this, I would like to conclude that vitreoretinal interface abnormalities results can present in different variety of clinical picture, and this requires lot of interventions. Common intervention is vitrectomy, ILM peeling, and tamponade agent. However, if there are additional changes that need to be applied case to case basis, and most of these disorders results in a good visual acuity. That is more important. So we should not neglect clinically and intervene and give a good visual outcome. Thank you for this opportunity.
Thank you, Dr.
And I
Ajit
given
Babu.
you 3 minutes.
That is a lovely talk, very nice images. While Dr. Rashmin comes on, I'll just ask you one question. Recently, the Optos company has launched one OCT, wide-angle fundus camera, which also does peripheral OCT at any point almost till the equator. And I saw a very interesting presentation in which they many of the cases of white without pressure, etc., essentially were all addition of the vitreous to the retina.
Yeah,
And
it's
so
now yeah.
is there a case that earlier at before doing LASIK they used to do 360 degrees barrage? So cases in which if we have these technologies where we are seeing addition in the peripheral retina, would it still make sense to kind of do a 360 degrees barrage before doing procedure like a LASIK or cataract surgery?
I'm a critic of doing excess barrages.
Okay.
I'm very, very sparing and conservative in doing lasers.
Right.
Because everyone thinks that by barraging the laser, you are protecting. You are not protecting. You are creating a temporary strong adhesion in that area.
Which
But
again
what
can
will
induce
happen to the edge of that strong area? Again, there is
when
a weak
PVD
and
happens.
strong area.
Yeah.
So that really, it gives you a false sense of
Security.
protection, where you will say patient that you be yourself, and you are putting him into more danger rather than a protection.
Thank you.
Yeah, PVR can get enhanced actually with laser.
Yeah.
And the vitreous, the liquefaction will also get enhanced. So you are enhancing the disease process also. So I am very, very conservative.
Thank you, sir.
Thank you.
Next speaker is Dr. Rashmin Gandhi. He is at the Center for Sight, Hyderabad, and he will tell us about what's new in optic neuritis.
Thank you, Rishi. Thank you so much. Thank you, Telangana Ophthalmology Society, AIOS, Rishi Swarup, Dr. Babu, Dr. Mathur, for this very kind invitation. So our knowledge of optic neuritis, and I always start this talk with this slide, not because my photograph is on it, but because I really like to say that how our knowledge has progressed, and that's where we'll realize that the new is really new, number one, and number two, it has put us as an ophthalmologist, not only neuro-ophthalmologist, as an ophthalmologist at almost at a centerpiece to manage optic neuritis. It's not now enough for us to say that it's likely optic, no problem, send it to neurologist and they'll manage it. We have a very major role to play, and that has come about because of this new knowledge that we have gained. Now, what is the significance of this slide? Now, in around 18th century, it was believed that optic nerve is a hollow tube which transmits all the senses from outside to the brain. So it's called sensus communalis tube, and that's where we get the word common sense. You know, the all senses go there. So this gentleman from UK, Walter Bailey, thought that if somebody loses vision because of an optic nerve problem, maybe the bad spirit has traveled to the brain through the optic nerve. And so the treatment is to get the spirit out from the head. So he probably would have thought for some time and said that, oh, we can get these spirits out by instituting a very, very simple treatment. Would anybody venture saying what he would have thought for a long time and come up with the treatment? The photograph is the clue, and some of us on the stage are the clue. Well, what would have Walter Bailey thought? Oh, if you want to take out the bad spirit from the head, do this 4 times a day and you'll be fine. Your optic neuritis will be treated. So he suggested that maybe you should comb hair 4 times a day for 2 minutes. So 2 minutes, 4 times a day. Obviously, he didn't think of some of the people, if they would have got optic neuritis, what they would have done. But from there, from that kind of thought process, we have now come to a modern science where we know a lot about optic neuritis. So the older concept of optic neuritis is that you suspect optic neuritis only if you see a young female with an acute loss of vision with pain which exhibits optic nerve dysfunction. That is what a last study which was done in the US, ONTT, told us, that it is a disease of a young female, and it is much more common in Caucasians. It's not so common in other species, other races. We also thought that most of these patients would have reasonable retaining of vision when they present to us. Most of these optic neuritis would be retrobulbar neuritis, no disc edema, and it is unheard of, according to the older literature, that optic neuritis will be bilateral. We also thought that all these patients would recover whether or despite we intervene or we don't intervene. At the end of 6 weeks, whether we give steroids, don't give steroids, all the patients with optic neuritis will recover good vision. Role of MRI, if you can afford, patient can afford, do MRI. Otherwise, MRI, if you don't do MRI, it's all right. And steroids, again, same thing. You give steroids, great, the recovery will be faster. If you don't give steroids, it's all right. So with that background, now we say what has changed? Why we're talking about these things, saying that, okay, last 7-8 years, we now have some new knowledge in optic neuritis. Well, all these have completely reversed. And that has happened because of this discovery of these two antibodies. We know that these two antibody-mediated optic neuritis, which is NMO and MOG, they are much more common. That optic neuritis is much more common in Indians. They are very different from what I described or what we have known so far, and their management and also investigation is different. How are they different? When do we know that we are dealing with an optic neuritis, but it is not really something which is described in textbook? When patient comes to you with an acute loss of vision at any age, generally patient would have optic neuritis. Otherwise, we thought that everybody would complain of pain. But now we know that some of these antibody-mediated optic neuritis may be painless. They can have a bilateral simultaneous loss of vision, and some of them, or reasonable number of them, would have severe loss of vision on presentation. Within a week, patient would say that they'll come with 1/60 counting fingers vision, which was not really very common earlier. And generally, we believe that by the 3rd or 4th day of steroids, patient will start reporting an improvement, and by 6 weeks, patient will be normal. These patients would not report any improvement to steroids. And we also know that these, why should we be worried or knowing about it? Because these patients can have specific complaints like hiccups and uncontrollable vomiting. They have a very typical MRI findings which are different from what we see otherwise, or what has been described in optic neuritis, and that's the reason why change that MRI now is mandatory in everybody whom we suspect optic neuritis. 15 years ago, we would have said, okay, if you don't do MRI, it's all right. But now MRI is mandatory, because if you find any of these specific changes which are attributable to antibody-mediated optic neuritis, then the treatment is different. And how is it different? We give steroids as we would have given, and this is sometimes would happen in a neurologic clinic, but the threshold to institute or administer plasma exchange has become very low. Why is that? Because you have these antibodies which are circulating. They have attacked optic neuritis. Within a span of few weeks, same antibodies can attack spine, and the patient can end up with irreversible paraplegia. So if patient has come to you with optic neuritis, a lot of times now neurologists, with the first attack, if there are criteria which matches with these NMO or antibody-mediated optic neuritis, they would advise plasma exchange. And how would they know that it matches the criteria? Because of our report. What our report should be, that there is a severe loss of vision, probably a bilateral loss of vision, while other eye patient is not complaining. Patient has disc edema. This is something which neurologists will not know, that patient whether has a disc edema or no disc edema. OCT findings, generally OCT again has become a cornerstone in investigation and management of a lot of these optic neuropathy. If patient has what was described as a typical optic neuritis, OCT in an acute phase may be normal or may exhibit thinning in the temporal area. While in these cases, antibody mediated, generally initially there will be increase in the RNF thickness, because most of these patients would have disc edema, and very soon as the axons start dying, you will have global decrease in the RNF thickness. And also these patients, it's not enough to give them steroids and plasma exchange. They all would require azathioprine, rituximab, and this decision of course is neurologist, but he needs to be told that this patient probably is falling into NMO spectrum disorder. Similarly, the other antibody is MOG, which has a similar spectrum. They may present to neurologists because they also can have an associated encephalitis-like symptom. This is much more common in children. MOG-related optic neuritis has a better prognosis than NMO because they can recover faster, and the neurological deficit is not that common. So to conclude, why this new knowledge is relevant, we need to advise for MRI brain in orbit with contrast in all patients who have optic neuritis. everybody should be given steroids because steroids seem to be preventive of further attack on the spine and other neurological structures. Lower threshold for plaques, long-term immunosuppression, and also if we can give these information to neurologists that it may be falling into NMO spectrum, then they would not be in a hurry to start the agents called interferons. Interferons are generally given to modify the disease process in multiple sclerosis, but if it is not falling into MS but into one of these, then actually you are patient might be harmed. Thank you.
Thank you, Rashmin. Actually, it's very enlightening talk. What percentage of optic neuritis are NMO and what percentage MOG?
So unfortunately, we don't really have the data to say. There have been some data from Singapore, and we can say that maybe our patients will be behaving similar to what happened in Singapore. So around 43% of all optic neuritis had. Now, when you say NMO, again now there is a subdivision. You do a cell-based assay and you find the antibody. Then it's confirmed that it's NMO. But a lot of times you don't find an antibody, but you still label it as NMO. So 43%.
Okay. Thank you very much, Rashmin. And now we will move on to the next speaker. Does he require an introduction? People ask me to introduce. I don't want to introduce. Actually, I spent most experience with him, along with him. We work together in co-management, and I really get thrilled with the amount of dedication he has, not only towards clinical care, but towards academics and then to the society. I introduce Dr. Santosh Hanawar.
Thank you, Ajit, for your kind words. I'll be speaking on plaque brachytherapy in ocular surface tumors. If you go by the literature, you find surprising evidence that 25 to 40% of ocular tumors that you think you have excised well ultimately recur over a period of time, impacting vision salvage, eye salvage, and each recurrence unfortunately adds to the metastatic potential of the tumor. So it's best to avoid recurrences, and for that reason we incorporate what are called oncological principles in the management of these tumors. The most important oncological principles are that the excision should be complete. How do we know excision is complete? You have to have histopathological evidence of edge as well as base clearance. Now, while edge is very easy to determine, if you look at this patient on slit lamp, you know where is the tumor and where is normal conjunctiva. So you can excise the tumor completely with clear conjunctival margins, that's for sure. But what about the base? Base is opaque. You only have a clinical judgment here to assist you. You can try to move the tumor with a wet cotton tip applicator on slit lamp and see if the tumor moves. If it moves, perhaps it is not attached to sclera. That's all you'll know. You don't have any information whether it is infiltrated the tenons already. So base is difficult to assess. Fortunately, we have OCT and UBM helping us in assessing the base. We know how deep is the tumor by doing a OCT or a UBM. This patient has a corneal OSSN. This is normal corneal stroma. In this portion, the corneal stroma is splayed. It also has higher internal reflectivity, indicating that there is corneal stromal invasion already. Fortunately, good news is that OCT correlates with histopathology. So in this patient, the conjunctiva is full thickness involved. This bubbly layer being tenons is not involved. We excise it, conjunctiva is involved and the tenons is not involved. So we have something to go by when we do surgery for these patients. Surgery would mean excision with edge and base clearance, alcohol-assisted keratoepithelectomy and excision edge cryotherapy. It works very well. But what if sclera and cornea are involved, and if the patient has intraocular extension? What if base is positive on histopathology? You have believed OCT, you have believed UBM, you have believed your clinical judgment, you have excised the tumor, but base comes positive on histopathology. What do you do? These are something that go beyond surgery. Earlier we were doing as a routine, as a matter of protocol, extended enucleation and exenteration in these patients who have intraocular extension or base positivity, because you cannot excise the sclera and let the eye survive. Now we have plaque brachytherapy. We use ruthenium, which is a beta emitter. There are two variations of plaque brachytherapy. One is called primary plaque brachytherapy. That means you do it without doing surgical excision or at the time of surgical excision. When sclera and cornea are tectonically suboptimal, that means there is some stromal melt already where excision is not possible without compromising on the tectonic integrity of the eye, then you do only an incisional biopsy to confirm the diagnosis if there is a diagnostic dilemma, and proceed with primary brachytherapy. So you don't excise the tumor, you only diagnose it, confirm histopathology and proceed with excision, proceed with brachytherapy. When an imaging has preoperative evidence that the corneal stroma or sclera are involved or there is limited intraocular extension, then you can go ahead with primary plaque brachytherapy. These are the steps that we follow: clinical diagnosis, followed by tumor measurement, followed by OCT or UBM or both to measure the height of the tumor. Then you calculate the dose of the tumor. This is called dosimetry with isodose curves, looking very carefully as to how much dose the lens is getting. Will it become cataractous? Then once that is done, you go ahead with surgical excision. This is a patient where twice earlier excision has resulted in recurrence because base was not taken care of by the previous surgeons, despite the histopathological evidence of base positivity. So the awareness is something that has to be created, that when base is involved, you have to do something more to the patient rather than just give topical mitomycin. That will not work for the base. So you carefully excise the tumor after having delimited its extent clinically. In this patient, the lateral rectus insertion was also involved. In such situations, we do an MRI with contrast to assess how much of the lateral rectus is already involved and excise part of it and recess it and leave it back. So that does not affect the motility so much. So once that's the lateral rectus muscle being tagged and portion of it is being excised along with the tumor. Now you go for lamellar excision. This is not lamellar sclerectomy. This is in flush with the rest of the sclera. Complete excision with edge clearance and excision edge cryotherapy. All these are parts of the surgical process. So we have excised the tumor, all right, but what about the portion of the tumor that is left in the sclera that needs to be treated, for which you do brachytherapy. Now, depending on the limitation of the size of the plaque that you have at your disposal, you can use brachytherapy once or even twice. That's called rotational brachytherapy, to cover the entire base of the tumor, not just the area that you think is appropriate to be covered. So entire base of the tumor has to be covered either as primary or as rotational setting. Then once you're done that, you get this kind of results with primary plaque brachytherapy. This patient has corneal stromal melt and scleral melt, so you can't excise it. It will leave a gape in the eye tectonically. Obviously, you can't repair an eye with tumor. So you do a safe biopsy from a portion of the tumor, confirm it is indeed OSSN that you're looking at, and then place a plaque on top of it. As long as physically it is possible to place a plaque on top of the tumor, it is possible to operate on this. This is one more patient where there is stromal involvement, where primary plaque brachytherapy was done without excision. And of course, you follow them up regularly. Secondary brachytherapy is when you're not sure of the base, but when you send the sample, excised sample, to the pathologist confirms that there is base positivity, then you do a secondary plaque. That means you have already reconstructed the ocular surface with conjunctival autograft or amniotic membrane or whatever. And then once the pathologist confirms the diagnosis that there is base positivity, as per the protocol for adjuvant therapy, you do plaque brachytherapy. This is how it works. So this patient has scleral involvement confirmed on histopathology. Then we do adjuvant plaque brachytherapy for the scleral residual component. It works very well. Sclera is collagen rich, and collagen rich tissue does not melt with brachytherapy. So that's a great advantage that we have, that we can deliver high dose of radiation to the sclera, yet it does not get chained. Similarly, for conjunctival melanoma, diagnosis is fairly simple. This is a patient where conjunctival melanoma has been excised earlier. This is PAM related melanoma with diffuse involvement. Unfortunately, other eye of the patient has had trauma and he has suboptimal vision. He has a macular hole as well. Now we have to save this eye, which has 6x6 N6 vision, potentially seeing eye. But when we did UBM and AIOS2025-GP107, we realized that he also has a ciliary body involvement. Earlier, this was a clear-cut case for extended enucleation for or orbital exenteration. But now treatment is possible. We carefully excise the tumor, entire pigmented area, that is PAM and tumor. Here again the muscle insertion is involved, so dissect that segment of the muscle and perform rotational plaque brachytherapy to the entire ocular surface, and this is how well he does. Not all patients respond so well. We have only 90% success with this. 10% patients still need extended enucleation or orbital exenteration, but that's really gratifying that at least 90% of these eyes can be saved. One more similar example. That's the success rate we have. Complications, of course, are there. Limbal stem cell deficiency is a complication that we noted very early in the course of our management. So what we did was we currently modified the technique to incorporate primary SLET in these patients, where patients have an extensive limbal involvement, we already do a slit. So the chance of having limbal stem cell deficiency as a secondary complication is minimized, although not zero. We have published this recently. The primary plaque brachytherapy has not yet been published, but secondary plaque brachytherapy results have been published. So it's a multimodal treatment that you do. You excise it, you do cryotherapy, you also do radiation, so that these patients who have corneal stomal or scleral involvement or limited intraocular involvement can be salvaged. Thank you so much.
Thank you, Dr. Santosh. It's amazing how many ever times one listens to you, there's always something to learn. You're an amazing teacher, and I'm sure the audience has the same to say. So we're well on time, and I'd like to thank all the speakers and the chairpersons and the audience for sitting through. We have a reasonable sized audience for a near lunch session. So thank you all, and come to Telangana Ophthalmological Society in July, annual meeting in July.
MP has already had lunch, I think.
Our dates for the TOS annual meeting are July 11th to 13th. Thank you. One group photo, please, all the speakers.